This is a short summary on the scenarios of case 6. So our patient is Miss Sherry Peters, a 28-year-old female admitted to the ward via the A&E. So she presented with a complaint of hematemesis after drinking excessive alcohol. Endoscopy shows that she has esophageal varices. Blood was given to her in the emergency department. She has poor venous access as she is an intravenous drug user. So the doctor could not perform double lumen PICC insertion on her. She also has jaundice and mild ascites. The patient's medical history shows that she has had schizophrenia and chronic back pain, and the drugs that she is currently on or has been on include temazepam, methadone 80 ml per day from Recovery Nottingham, and we got this information from the patient, ibuprofen and gabapentin for her chronic back pain, as well as omeprazole. It is useful to note that the patient has an allergy to penicillin. Social history of the patient. She lives with her partner. She has 2 children which are on child protection plan. She is an ex-IVDU and she admitted that she just used heroin last week. She smokes 40 cigarettes a day. Upon admission, her temperature was recorded to be 38.1 degrees Celsius, blood pressure 102/67, and redness and pus was also found around in the injection site in her groin area. So the doctor decided to start talipressine to stop her bleeding, flucloxacillin 100 mg, methadone 80 mg, paracetamol 1 gram 3 times a day, enoxaparin 40 mg subcutaneously, as well as chlordiazepoxide. Besides that, there's also been planned to contact safeguarding team about her children. Further drug history is also needed, so the doctors will need to check her summary care record, Pabrinex, wound swab, and hepatitis screen. The hospital pharmacies called up Sherry's community pharmacies, asking for details about her methadone prescription. It was found that Sherry takes 60 ml a day, and she did not collect her methadone since the last 3 days. 3 days later, the doctor decided to stop talipressine as the bleeding has been controlled. Wound swab showed that MRSA and Clostridium strains are positive. If abscess is present, the doctor will perform incision and drainage. So Sherry has to be isolated and barrier nursing has to be carried out as she's been infected with the superbugs. So after that, the doctors stopped Sherry on flucloxacillin. If you remember previously, we stated that Sherry is allergic to penicillin. so it has been changed to clindamycin, which the doctor then changed to vancomycin due to S. aureus resistance. So Sherry has been started on metronidazole as she is Clostridium sensitive. Enoxaparin has been stopped because she is at risk of bleeding. Paracetamol and methadone is continued. And doctors has decided to switch Sherry from omeprazole to ranitidine. Pabrinex, propranolol and lactulose has been started on her. Sherry's pre-dose for vancomycin is 17 mg per ml, which is above the target pre-dose. After 2 weeks, Sherry grows increasingly aggressive towards patients and staff on the ward. She keeps leaving the ward to smoke, and the nurses are concerned that she is putting something down her PICC line and coming back looking very out of it. A bottle of alcohol was also discovered in her bed after her partner has been to visit. She tells the pharmacist that her tablets are the wrong color and that she thinks the nurses are trying to poison her. Sherry has been started on intramuscular lorazepam, 2 mg, and intramuscular haloperidol, 5 mg. And she is being monitored by the nurses every 5 minutes. Acute dystonia was noted, and therefore procyclidine 5 mg intramuscular was administered to Sherry. So the plan is to refer Sherry to a psychiatrist for review and also consider about sectioning. Sherry is well known to the mental health team. She was diagnosed with schizophrenia after the birth of her first child after an episode of postpartum psychosis. Sherry is currently on intramuscular Risperdal Consta, and she last took it before Christmas. It is felt that a Section 2 is not required at present, as Sherry recognizes the need for treatment and is willing to engage. So the plan is to give Risperdal Consta 37.5 mg intramuscularly as soon as possible. Prescribe as required lorazepam orally, 2 mg first line, and then lorazepam intramuscularly 2 mg only if necessary. Maximum dose would be 4 mg every 24 hours. Haloperidol should be avoided at all costs. So the nurses called up the medicines information department to ask about how to administer Sherry's Risperdal Consta, as they have never given it before. Sherry is quite agitated and aggressive, and the nurses would like to know how long will it take for the medicine to work. Sherry is discharged from the hospital. Her TTO included medicines like gabapentin, 300 mg 2-3 times a day for 14 days, methadone, 60 mg once daily for 14 days, propranolol, 80 mg twice a day for 14 days, temazepam, 10 mg once at night for 14 days, thiamine 100 mg 3 times a day for 14 days, and vitamin B co-strong 3 times a day for 14 days. Lactulose and lorazepam was discontinued. 1 month later, Sherry is sent back to the hospital. Upon admission, the doctors assess her risk for DVT. It has been observed that Sherry has pitting edema at her left leg. Her left calf circumference is 22 cm, while her right calf is 16 cm. There's tenderness and swelling at her calf. The doctors ordered for clotting screen and blood tests to be carried out. Her clotting screen turned out to be normal, and her blood results are still pending. The plan is to start her on anticoagulation treatment along with D-dimer.